Thank you for joining us today for the latest in GBinsight's Genetic Medicine webinar series. Today, we are very excited to have Professor Robert Rosenson give us a presentation titled, Why Does a Genetic Diagnosis of Familial Hypercholesterolemia Matter? Robert Rosenson is a professor of medicine at the Icahn School of Medicine at Mount Sinai and director of Metabolism and Lipids at Mount Sinai, New York. Professor Rosenson is an internationally recognized clinician and researcher, having published pioneering work on inflammatory processes and atherogenesis. He is principal investigator for multiple international trials investigating novel therapeutics for hyperlipidemias, including an NG3 inhibitor program. Professor Rosenson has received numerous awards in recognition of his contributions. But first, some quick housekeeping. We will have a few minutes at the end of Professor Rosenson's presentation for Q&A. If you have a question, please type it into the Q&A box at the bottom of the Zoom browser. We will try to get everyone's questions while also being cognizant of Professor Rosenson's time. This webinar is now being recorded, and a copy of it will be available on the GBinsight webinars webpage within a couple days. Okay, so let's get into today's presentation. Dr. Rosenson, the floor is yours.
Hey, good morning, everybody. These are my disclosures. I'm going to begin with a case. 36-year-old young man, newly detected hypercholesterolemia. His cholesterol was 229 milligram per deciliter, LDL cholesterol not so high at 152 milligram per deciliter. He was placed on a low-fat, low-cholesterol diet. His LDL cholesterol actually increased to 173 milligram per deciliter. Based on this hypercholesterolemia, this increasing LDL cholesterol level, he was referred to me for evaluation. On the examination, he had mild thickening of the Achilles tendons, not the full-blown tendons xanthomas we're used to seeing, but the tendons were abnormal. And he had a murmur consistent with aortic valve sclerosis. This prompted me to think about the diagnosis of familial hypercholesterolemia, but recognized that the skin findings were minimal compared to what we're used to seeing for patients with that genetic disorder. Using the Dutch lipid score, if we assume that those irregularities were tendon xanthomas, based on his LDL cholesterol level, he has a diagnosis of probable familial hypercholesterolemia. But we really need more information, and let's review the family history in a moment. So, what are the limitations of these clinical screening tools? Well, things have changed over the last several decades because people with high cholesterol, even without a genetic disorder, are put on cholesterol-lowering therapy, beginning with a statin. That changes the onset of heart disease that is not necessarily early onset at all, and also changes the findings that we see in the skin, such as the xanthelasmas, the dense corneal arcus, and the tendon xanthomas. So our ability to use these clinical tests are more challenging now because of the widespread availability of cholesterol-lowering therapy. And these data from the Spanish Familial Hypercholesterolemic Cohort Study and the Cascade FH Registry, few individuals have xanthelasmas or have xanthomas or have corneal arcus. We need to rely on genetic testing to help us with the diagnosis. And then throughout this presentation, I'll explain why making a diagnosis of familial hypercholesterolemia is important. What is familial hypercholesterolemia? This is a condition that results from a defect in the ability to remove LDL from the circulation due to an impairment in the LDL receptor. That impairment may be at the level of the receptor or the ligand that interacts with the receptor, apolipoprotein B, or one could degrade the LDL receptor by having gain of function mutations in PCSK9 or proprotein convertase subtilisin connexin 9. But this condition is associated with early onset atherosclerotic cardiovascular disease, and this is why we are concerned. So when we think about the differential diagnosis, we know that he's on a strict low-fat diet, so that's not a secondary cause contributing here. His thyroid panel is normal. He has no proteinuria and no abnormalities consistent with hepatobiliary disease. Other than the 3 causes of familial hypercholesterolemia that I reviewed, there are abnormalities in apolipoprotein E. There may be lysosomal acid lipase deficiency. You could have extremely high LPA level. You can have an autosomal recessive condition that may be the LDLR receptor adapter protein 1 or beta-cytosterolemia, or you could have polygenic hypercholesterolemia. So there are many diagnoses that we need to entertain to understand this individual's LDL cholesterol level. Now, genetic testing allows for more discrimination of these genetic causes, major genes, polygenes, and it actually helps assist us with our cascade screening, which is the assessment of lipid traits and genetic diagnoses in first-degree relatives, be it the parents, the siblings, or the children. And we've learned that an early diagnosis of genetically determined familial hypercholesterolemia results in more effective therapy that begins at an earlier age. In addition, studies have shown that there are more opportunities to add non-statin add-on therapies to reduce the LDL cholesterol in people that have known genetic traits versus those without. This analysis, which was summarized in the European Society of Cardiology Task Force Report on Familial Hypercholesterolemia, highlights the cholesterol levels in patients with 2 defects, known as homozygous familial hypercholesterolemia, versus 1 defect, heterozygous familial hypercholesterolemia. In the lines for the heterozygous familial hypercholesterolemia, the onset of heart disease begins at the age of 35. If they're put on a low-dose statin, you can delay the onset of heart disease to the age of 48. And if you're on a high-intensity statin, you can delay it to the age of 53 years or another 18 years. So again, a genetic diagnosis, early treatment makes a difference for cardiovascular morbidity and mortality in these individuals. Now, the picture is complicated. Even though we understand that homozygous familial hypercholesterolemia involves 2 traits, sometimes the same and sometimes different traits together, versus 1 trait in heterozygous familial hypercholesterolemia, there may be an overlap in LDL cholesterol levels, as shown to the left part of this graph, over here, about the 400, to 450 milligram per deciliter area. Other factors that influence the LDL cholesterol level in these individuals is if they have an LDL receptor null mutation, less than 2% of the activity, the LDL cholesterol levels are highest. If it's an LDLR defective trait, they're next highest, versus having gain of function in PCSK9 or apolipoprotein B. Those are familial hypercholesterolemia disorders associated with less severe elevations in LDL cholesterol. And other factors may influence the LDL cholesterol level, such as polygenes and also high lipoprotein A. It's critical to remember that when we encounter our patients who have ischemic heart disease, that 1 in 31 have a diagnosis of familial hypercholesterolemia. And if we evaluate individuals with premature early onset heart disease, less than 50 years in a man, less than 60 years in a woman, the prevalence is 1 in 15, or 20-fold higher than somebody who's got an LDL cholesterol level that's less than 130 milligram per deciliter. And if you have severe hypercholesterolemia defined as an LDL cholesterol level greater equal to 190 milligram per deciliter, 1 in 14 have familial hypercholesterolemia, or 23-fold higher than a lower LDL cholesterol level. So often our patients with familial hypercholesterolemia are presenting with a myocardial infarction before the diagnosis is made. Let's talk about genetic testing, methods, and access. In this analysis from Sturm, they evaluated individuals who have both a genotype positive for familial hypercholesterolemia, but a negative phenotype, so the lack of cutaneous bindings, as an example. Other individuals who have a positive genotype and a phenotype, and those who have a negative genotype and a positive phenotype. Those are the three different categories. And in those individuals who have a positive mutation, we can see that that genetic diagnosis is more common at the highest level of LDL cholesterol levels. But with regards to the case presentation today, be it his initial LDL cholesterol level between 130 to 160, and now the current one between 160 and 190 in the mid 170 milligram per deciliter, genetic diagnosis is still more common and associated with heart disease. So at any level of LDL cholesterol, having a genetic mutation increases the risk of heart disease. And why is that the case? Because this is a trait that was present before they were born, and it's a cumulative exposure to high LDL cholesterol that impacts on cardiovascular risk. Similar data was reported by Amit Kara and Sek Katharesan in this really landmark paper in the Journal of the American College of Cardiology. So for individuals with LDL cholesterol levels greater than 190 milligram per deciliter who had FH mutation negative, the risk of heart disease was increased sixfold compared to those with an LDL cholesterol level lower, less than 130 milligram per deciliter. But if they had a high LDL cholesterol and an FH mutation, the risk for coronary artery disease was increased 22.3-fold. So this is a marked difference and worth proceeding with genetic diagnosis to get a better understanding about the risk and, again, focus on aggressive treatment for those individuals. As I mentioned earlier, there are certain traits that are associated with higher LDL cholesterol levels, higher risk of heart disease than others. And the missense mutations in ApoB typically versus ones that are disease-causing versus, let's say, LDL receptor loss of function mutations have the highest rates for heart disease and the highest LDL cholesterol levels. So there is heterogeneity amongst individuals with familial hypercholesterolemia with regards to their LDL cholesterol levels and the risk of heart disease. This was also highlighted in this paper from Nature Communications, that those with the LDL receptor pathogenic variants have much higher LDL cholesterol levels than those with an ApoB pathologic variant versus those who have, loss of function mutations, let's say, in PCSK9 or apolipoprotein B. So again, consistent study from study, the LDL pathogenic variants, higher LDL cholesterol levels than the ApoB pathogenic variants. And that's shown graphically here in this in these bar graphs. Let's talk about polygenic risk. This is certainly an emerging area that has been used to better understand contribution to multiple diseases, including coronary artery disease and hypertension, type 2 diabetes, as well as ischemic stroke, atrial fibrillation. So let's talk about polygenic risk scores. Well, the higher the score, the greater the risk, based on this variable of interest. And we'll talk about this with regards to familial hypercholesterolemia in the next few slides. In this analysis by FAD, they looked at individuals who had monogenic traits, who had a high polygenic risk score versus intermediate versus low. And we can see that based on this percentile of polygenic score, that the odds ratio for coronary artery disease amongst these carriers increases. But interestingly, in individuals without an FH mutation, that the polygenic score also contributes to the risk of heart disease. So this is quite insightful information that tells us that we need to expand our screening with not only these monogenic assessments, but also the polygenes. And we'll move into our case presentation in a moment to highlight this issue as well. So this is data from Trinder. Again, very similar findings, study to study, which of course is reassuring. On the bottom, we can see that a monogenic trait, high polygenic risk score, the risk is increased threefold compared to a high monogenic trait, and a low polygenic risk score, 1.97, compared to those with a high polygenic score and a negative monogenic trait at 1.39. These data were summarized in the central illustration from the Journal of the American College of Cardiology, where you evaluate polygenic risk, monogenic variants, look at the combination, and that impacts on the LDL cholesterol, the variable of interest here, and impacts very much on cardiovascular events or event-free survival. So again, quite important. And going back to our study from CARA, they also reported high polygenic risk score had a lower LDL cholesterol than genetically confirmed familial hypercholesterolemia, but if you have both abnormalities, your LDL cholesterol level is the highest. And here we can see about 240 milligram per deciliter if you have both traits in this study. So let's move on to our case. Quite a complicated situation. So he has a LDLR receptor abnormality, heterozygous for that, and it's classified as a pathogenic trait. But interestingly, there's a PCSK9 loss of function variant associated with hypercholesterolemia. So there's a positive trait and then a negative trait that simulates a PCSK9 inhibitor. So this may be why his LDL cholesterol level is lower than one might have expected for somebody with familial hypercholesterolemia. But then we obtained the data from GBinsight on the polygenic risk score that placed him at the 99th percentile. So we've got a major LDLR trait offset somewhat by a loss of function variant in PCSK9, but then higher LDL cholesterol with a polygenic risk score. But I think this case highlights very much when the LDL cholesterol is not extremely high and you don't have the family history of early onset heart disease, but you're concerned about a genetic diagnosis, familial hypercholesterolemia in this individual who's not overweight, on a strict low-fat diet, exercises regularly, how genetics can really help figure out the LDL cholesterol level and better understand his cardiovascular risk. Now, how might the use of genetic traits predict the benefits of cholesterol-lowering therapies? So we're going to discuss some of the data on statins and PCSK9 inhibitors. So in the Fourier and the Odyssey study, they looked at individuals who had a high polygenic risk score, and we can see that the absolute cardiovascular risk was higher in individuals with a high polygenic risk score, here in these tan bars, versus those who had a low polygenic risk score. And so, compared to a low polygenic risk score, which is associated with lower risk, a high polygenic risk score, a higher risk. In this analysis that looks at individuals who are on placebo-controlled study compared to evolocumab, a monoclonal antibody, multiple cardiovascular risk scores or high genetic risk, had high events, and the use of evolocumab here on the panel C produces more benefit. The absolute risk reduction was 4%, or the NNT of 25, compared to individuals that didn't have the genetic traits, panel B, where you had to treat 71 people. So again, the higher the genetic risk, the greater the benefit of the treatment strategy. And this is the summary of this American College of Cardiology expert document led by Sturm that says that we are going to identify an index patient. In this patient of mine, we did not have an early family history. They died of other causes. And then we would, but if we do identify traits like in this young gentleman, we would provide genetic counseling to his first-degree relatives, his siblings, who, when we obtain the history, we're not aware that they may or may not have a high cholesterol level. And then by identifying other individuals in the family, we can get them diagnosed earlier, get them treated earlier, and potentially have an impact on their survival. So in terms of management, the treatment of familial hypercholesterolemia focuses on intensive LDL cholesterol lowering. And familial hypercholesterolemia is considered a coronary heart disease risk equivalent. So our minimal, and I underscore, minimal acceptable LDL cholesterol target is less than 70 milligram per deciliter. We begin with a high-intensity statin, and we can use either ezetimibe, a PCSK9, or perhaps bempedoic acid. So this patient was placed on rosuvastatin 40 milligram daily, but he exercises vigorously, and he went online and was concerned about adverse muscle symptoms, so we compromised and used a lower dose of rosuvastatin that dropped the LDL cholesterol to 72 milligram per deciliter. We're not at minimal acceptable goal. He's done what he can on diet. So we added ezetimibe. So in order to be successful with your patient, sometimes we have to be flexible, even though I would have preferred for him to begin with one agent at a much higher dose of a high potency statin. Well, how does genetic risk influence the response to statins? These are multiple clinical trials that show that individuals with a high polygenic risk score have the greatest benefit from the therapy. Again, gene pharmacotherapy interactions that were pretty consistent here across trial to trial. Seen that study with abalacumab. Getting back to the alirocumab data, the higher the genetic risk, the greater the risk of a coronary heart disease event, but also the greater the opportunity to derive benefit from a PCSK9 monoclonal antibody, is shown over here. The higher the LDL cholesterol, the greater the risk. These people actually lived longer in the Odyssey outcome study. And again, we're seeing the interaction between genetic risk and LDL cholesterol level, having both over here the highest risk, and the absolute benefit here, 9.2%. I mean, that's a massive treatment benefit. So genetics really has an important contribution to understanding not only the risk of our patients, but the opportunities to reduce their risk. So in the last few slides, there are limitations to genetic testing. We don't necessarily pick up all traits. Sometimes we get reports back of traits of unknown significance, perhaps not studied in the detail that we need to confirm a disease association. And I shared with you the data from the MIT-CARA that if you have a confirmed trait with a disease association, the risk is higher. It doesn't mean the other traits are not important, but you need to keep into account some of the limitations before you obtain the test and when you're counseling your patient. There are some concerns that patients may have about getting tested. We have good privacy laws and regulations with HIPAA. Sometimes they feel guilty by having a trait that they passed on to their children. But I would frame the discussion as an opportunity to help their family members before they have an event or before their tendons get loaded up with cholesterol and they develop tendonitis and perhaps an Achilles tendon rupture. Some of the issues in terms of cost insurance coverage are quite variable, but that's a topic that you may have to encounter or address with the people at GBinsight. So I want to thank you, and I apologize we had these technical issues, but I hope that you found this information useful, practical, for your practice, and I'd be more than happy to take any questions that you may have.
Thanks again, Dr. Rosenson. Just to reiterate, we apologize from our end too, and for kind of slowing things down. If you have time for a couple questions, if you could type it into the Q&A box or raise your hand. I'm going to start. Well, kind of people have just a question. Kind of go whichever way you want, Dr. Rosenson. Can you? I know Lp(a) is kind of all the rage these days, and it's perhaps one of the most prevalent genetic risk factors for. And then you mentioned there's also some publications mentioning that it can phenocopy FH. Can you describe in some detail kind of what's behind that, and also how that's treated clinically these days?
Yeah. So lipoprotein A does contain cholesterol, and if you have an extremely elevated lipoprotein A, that can contribute to the quote calculated LDL cholesterol, because LPA is in the LDL density range. So you have an elevated LDL cholesterol, but it's not nearly going to be the same as somebody with an LDLR defect. High lipoprotein A is associated with early onset heart disease. So then you get scores, based on your clinical tools for early onset, heart disease. And then, of course, those individuals may actually have heart disease at a very young age. And we've got, people in their, 20s, early 30s that have had myocardial infarctions due to having a high lipoprotein A level. We also know that lipoprotein A increases the risk in patients with heterozygous familial hypercholesterolemia. A beautiful study from Norgestart's group in Copenhagen that showed that a high LPA on top of an FH trait increased the risk even further. How do we approach lipoprotein A? Well, we don't have a lot of tools. Thus far, there are the PCSK9 inhibitors, which have been shown in both Fourier and Odyssey outcomes to lower LPA by about 25%, but the treatment response is quite heterogeneous, anywhere from 0 to 70%. And so, if you have an elevated LDL cholesterol and a high LPA on maximum tolerated statin, you would select a PCSK9 inhibitor before, let's say, ezetimibe, because ezetimibe will have no effect on lipoprotein A levels. There are multiple trials underway with selective LPA inhibitors. The Horizon trial is the first with pelacarsen, Odyssey outcomes with olpasiran, and then there are multiple other companies that have tools that maybe other siRNAs, small interfering RNA inhibitors, oral disruptors, and then, of course, there's gene editing. So the future is really focused on lowering LPA-associated risk, which is quite common, as mentioned, and about 20% of the population has a high lipoprotein A level. And so it's not inconsequential and associated with very early onset heart disease in many of the affected individuals.
Just to follow up, Dr. Britton asked about LPA apheresis and whether it's FDA approved, and is it effective?
Yes, so that's a good comment from Dr. Britton. Of course, LDL apheresis, has now been FDA approved for lowering lipoprotein A, and thank you for bringing that, technique up to my attention and for the group's attention. But certainly that is an approach that one can have if you don't have these trials ongoing, or if the patient has a high enough risk, based on the LPA, the LDL cholesterol, that and then you have the availability of LDL apheresis. Certainly that is an option for the patients. Thank you.
Okay. Do you have time for a couple more?
Yes.
Okay, so there's two here in the Q&A box. Can you discuss the management of kids presumably with FH? Yes.
So we do actually recommend screening in, children. Typically we're going to wait, for treatment until, greater than 2 years of age, when neuronal development is fully, developed. And, children are approved for, statins. Homozygotes are different. We're going to treat them much more aggressively, but the heterozygotes, the FDA has approved statins for boys age of 8, and for girls typically at the age of 11 or if, menarche. PCSK9 inhibitors have now been approved for the use in children. And this, was, based on a trial led by Raul Santos, with the Molecumab. So we understand the need to treat these children earlier and more aggressively than before. Now, there is an American Heart Association statement from many years ago that's recommending less aggressive therapy than the newer data might indicate. At least in my opinion, that's a scientific statement. It was led by Sam Giddings. It really needs to be updated and get in more in line with the newer genetic studies and the newer longitudinal studies. The Spanish study I think has tremendous impact for me. This is a study of individuals who have genetic confirmation of familial hypercholesterolemia, and then they had to have a sibling, so the same home, same food, same environment, without an affected trait. And the early treatment in these adolescents, over 20, 30 years, was effective in lowering the risk of heart disease such that they were no different than their siblings. And so I'm a big advocate for early treatment in young individuals. Now, I have one of my pure homozygous patients, of course, he's got 3 sons who have, heterozygous FH, they have high LPA. And when I saw them at the age of, 5, 8, and 11, they already had aortic valve murmurs and had thickening in the Achilles tendon. Of course, their father, had a myocardial infarction and, coronary bypass surgery at the age of 24. So this highlights the interaction between LDL cholesterol, certain mutations with, negligible LDL receptor activity, and then throw on a high LPA. And I'm glad that I've treated them, because, they haven't progressed to aortic valve stenosis, and their Achilles tendons, have become less thick with, very effective cholesterol lowering agent. They responded well to, the combination of statin and ezetimibe, treatment. So, yeah, I do support, early detection in children and treatment. And of course, if you have a homozygous patient, a lot of times they're, these, toddlers, present with, cutaneous xanthomas where they faint because they have subvalvular aortic valve stenosis. And so the point is that we've been waiting too long to treat, children. And there's actually a scientific statement, from European Society of Cardiology, EAS, about doing, CT angiography, in some of these young, children to see if they have coronary disease, because they also die of myocardial infarctions, and it's a real tragedy. And there are therapies that are available approved for children, including an angiopoietin-like 3 protein inhibitor, which works independent of the LDL receptor and lowers LDL cholesterol by about 49%. And as Dr. Brinton appropriately mentioned, LDL apheresis is a very, useful option as well for these homozygous patients. And not mentioned, because this is not a whole talk on pharmacotherapy, lomidopide is approved for homozygous FH patients and works also by an LDL receptor independent mechanism.
TP. Okay, so lastly, Dr. Peisler asks if you can explain the ApoE variant pathophysiology that you mentioned, presumably the leucine 167 deletion in severe hypercholesterolemia.
I'm not sure how much.
Okay, I was going to offer my 2 cents in here, which is that that variant occurs within, so it's an in-frame deletion of a single leucine variant. This is the one that's been reported in multiple individuals with hypercholesterolemia or FH or autosomal dominant hypercholesterolemia. It occurs within the ApoE region that binds, there's I think about 10 amino acids that's required within ApoE to bind to LDL receptor family members. So it occurs within that region. Some functional studies have shown that that deletion basically confers the inability to bind to the LDL receptor or LDL receptor family. So I believe that's that you had mentioned that in I think one of your slides.
Yes, I did in the differential diagnosis. Yes.
Yeah, so I believe that's what Dr. Peisler was referring to. I'm going to let you go and thank you, Dr. Rosenson, for providing this insightful information for us. And I once again want to apologize for putting you through the ringer this morning. And thanks for all of our attendees.
Yeah, thank you all for your participation, and I enjoy the questions. That's useful for everybody. Thank you.
All right.